Palpitations. Causes, symptoms, management.
Hello, everyone. Welcome to this comprehensive clinical session on palpitations, one of the most common yet most misunderstood cardiovascular symptoms. Whether you are a medical student, a postgraduate, or a practicing clinician, this topic is clinically crucial, exam relevant, and very frequently encountered in real-life practice. So let's break palpitations down, logically, clinically, and confidently. Palpitations are among the commonest cardiovascular complaints in both OPD and emergency settings. The challenge is this: some causes are completely benign, while others can be life-threatening arrhythmias. Patients are often extremely anxious. Many come repeatedly, fearing heart disease. So mastering palpitations means you become a better clinician and a smarter exam performer. By the end of this lecture, you will be able to clearly define palpitations, understand the pathophysiology, differentiate various causes clinically, take a focused history, interpret ECGs confidently, and approach palpitations in a safe, structured, stepwise manner. This is not just theory, this is real-world medicine. Palpitations are best defined as an unpleasant awareness of one's own heartbeat. The patient may describe it as fast or slow, irregular, pounding, fluttering, or even heart jumping in the chest. Patients rarely use medical terms. They say things like, "Doctor, my heart is racing. It skips a beat. Something is fluttering inside. My heart suddenly starts pounding." Your role is to translate these words into clinical possibilities. Remember, palpitations are a symptom, not a diagnosis. Our job is to find the cause. Now, this is a very important point to understand. Palpitations are not the same as arrhythmia. Most arrhythmias, especially serious ones, do not cause palpitations, and most patients who experience palpitations do not have a dangerous rhythm problem. What the patient is often feeling is an increased awareness of cardiac activity rather than the abnormal rhythm itself. This is the real clinical challenge. There is often a disconnect between what the patient feels and what the ECG shows. And that is why palpitations demand careful listening, thoughtful assessment, and measured reassurance. Let's briefly look at the epidemiology of palpitations. Around 16% of patients presenting with cardiac symptoms report palpitations as their primary complaint. In the emergency department, this translates to roughly 5 to 6 cases per 1,000 visits, making it a very common presentation. Importantly, about 1 in 4 requires hospital admission, highlighting that palpitations cannot be taken lightly. They are seen across all age groups, but are especially common in young adults, pregnant women, where the prevalence ranges from 3 to 11%, athletes, and the elderly. So palpitations are not rare. They are frequent, diverse, and clinically significant. Now, let's look at the etiological classification of palpitations. Roughly 43% of cases have a cardiac cause, most commonly arrhythmias. Interestingly, nearly 1/3, about 31%, are psychiatric in origin, highlighting the strong link between palpitations and anxiety-related disorders. About 10% fall under miscellaneous causes, including metabolic and drug-related factors. And nearly 16% of patients, no clear cause is identified, even after evaluation. This distribution reminds us of an important lesson. Palpitations are multifactorial, and a balanced, open-minded approach is essential. Let's begin with the cardiac causes of palpitations, specifically arrhythmic causes. The most common are premature beats, premature atrial contractions, or PACs, and premature ventricular contractions, or PVCs. These are often felt as skipped or extra beats and are usually benign. Next are the supraventricular tachycardias, including AV nodal reentry tachycardia, AV reentry tachycardia, and atrial tachycardia, classically presenting with sudden onset, rapid palpitations. We then have atrial fibrillation and atrial flutter, especially common in older patients and those with structural heart disease. More serious causes include ventricular tachycardia, which should always be considered a medical emergency until proven otherwise. Finally, don't forget bradyarrhythmias, sick sinus syndrome, and advanced atrioventricular block, which can also present with palpitations, often along with dizziness or syncope. So, arrhythmic causes range from benign to life-threatening, and careful evaluation is essential. In premature beats, the sensation of palpitations follows a very characteristic mechanism. A premature contraction is followed by a compensatory pause, during which ventricular filling increases. This leads to a stronger subsequent contraction, a phenomenon known as post-extrasystolic potentiation. The patient typically perceives this as a skipped beat, followed by a forceful thump in the chest. Understanding this mechanism explains why even benign ectopic beats can be felt so prominently. Structural heart disease is another important cardiac cause of palpitations. Among valvular lesions, aortic regurgitation produces a hyperdynamic circulation and prominent heartbeat awareness, while mitral stenosis commonly predisposes to atrial arrhythmias. Cardiomyopathies, including dilated and hypertrophic cardiomyopathy, are frequently associated with palpitations due to electrical instability. Palpitations may also occur in congenital heart disease and in rare but important conditions like atrial myxoma and arrhythmogenic right ventricular cardiomyopathy. Inflammatory conditions like myocarditis and pericarditis, as well as pulmonary embolism, can present with palpitations and should not be missed. The key message is clear: palpitations in structural heart disease always warrant careful evaluation. Certain structural heart diseases have very characteristic clinical clues that help narrow the diagnosis. In aortic regurgitation, palpitations are related to an enlarged left ventricle and a hyperdynamic precordium, leading to strong heartbeat awareness. Atrial myxoma may present with positional palpitations, often accompanied by a diastolic murmur that can vary with posture. In hypertrophic cardiomyopathy, palpitations are typically exertional and should always raise concern for malignant arrhythmias. Recognizing these patterns can be clinically decisive. A large proportion of palpitations arise from non-cardiac causes, and these must always be considered. The most common are anxiety and panic disorders, followed by thyrotoxicosis and anemia. Physiological states such as fever, dehydration, and hypoglycemia frequently produce sinus tachycardia and palpitations. Electrolyte disturbances can trigger both benign and serious arrhythmia problems. Rare but important causes include pheochromocytoma and mastocytosis. Autonomic dysfunction, such as postural orthostatic tachycardia and increasingly post-COVID syndrome, are now well-recognized contributors. This wide differential reinforces the need for a broad, systematic approach to palpitations. Psychiatric palpitations have some distinctive characteristics. Episodes tend to be longer in duration, often lasting more than 15 minutes, and are frequently associated with dyspnea, dizziness, chest tightness, and a profound sense of fear or impending doom. Recognizing this pattern helps avoid unnecessary testing while ensuring appropriate reassurance and care. Several commonly used substances can precipitate palpitations. These include caffeine, tobacco, and alcohol, as well as recreational drugs like cocaine, amphetamines, and cannabis. Among medications, beta agonists, theophylline, thyroxine, and digoxin are well-known triggers. Equally important are QT prolonging drugs, which may predispose to dangerous arrhythmias. A careful drug history is therefore essential in every patient.
Certain populations deserve special attention. In athletes, increased vagal tone and atrial enlargement can predispose to rhythm disturbances. During pregnancy, expanded blood volume and increased catecholamines commonly lead to palpitations. In the elderly, the risk of atrial fibrillation and ventricular tachycardia is significantly higher. Among post-COVID patients, palpitations may reflect myocarditis or autonomic dysfunction and should be evaluated thoughtfully. The primary goal of assessing palpitations is threefold. First, to identify life-threatening arrhythmias. Second, to detect underlying structural heart disease. And third, to stratify patients into high-risk and low-risk categories. This structured approach guides safe and effective management. Certain features immediately raise concern. These include syncope or presyncope, palpitations occurring during sleep, and exertional palpitations, a history of coronary artery disease or cardiomyopathy, a family history of sudden cardiac death, or an abnormal ECG are particularly alarming. The presence of any of these red flags mandates urgent and thorough evaluation. History remains the most powerful diagnostic tool in palpitations. Key elements include the age at first episode, frequency and duration, and whether the rhythm feels regular or irregular. The nature of onset and termination, abrupt or gradual, provides crucial clues. Always ask about triggers, such as exertion, emotional stress, posture, or substance use, and about relieving factors, including vagal maneuvers. A focused history often points to the diagnosis even before investigations. Certain symptom descriptions are highly suggestive of specific rhythms. A sensation of a skipped beat followed by a thump typically reflects PACs or PVCs. Regular rapid fluttering suggests supraventricular or ventricular tachycardia, while irregular fluttering is characteristic of atrial fibrillation. A pounding sensation in the neck points toward Canon A waves, classically seen in AV nodal reentry tachycardia. Associated symptoms significantly enhance diagnostic accuracy. Chest pain raises concern for ischemia or pericarditis. Dyspnea may indicate heart failure or a sustained tachyarrhythmia. Lightheadedness or syncope suggest hypotension and hemodynamic compromise. A combination of flushing, headaches, and sweating should prompt consideration of pheochromocytoma. Physical examination helps confirm the presence of arrhythmia and assess its hemodynamic impact. Findings may be entirely normal between episodes, but examination remains essential. It plays a key role in risk stratification and in identifying underlying structural heart disease. Vital signs offer immediate clinical insight. Heart rate may reveal tachycardia or bradycardia, while hypotension signals instability. Fever points toward infection or thyrotoxicosis. Pallor suggests anemia, and tremor or hyperreflexia raises suspicion of hyperthyroidism. Always look for signs of stimulant or drug use. Neck examination can be remarkably informative. Canon A waves indicate atrioventricular dissociation. Prominent neck pulsations are often seen in AV nodal reentry tachycardia. An elevated JVP suggests heart failure or cardiac tamponade. Positional variation in JVP may point toward atrial myxoma. Auscultation provides valuable diagnostic clues. A mid-systolic click suggests mitral valve prolapse. A harsh systolic murmur that increases with Valsalva is typical of hypertrophic cardiomyopathy. A diastolic murmur raises concern for atrial myxoma or valvular disease. A hyperdynamic precordium is characteristic of aortic regurgitation. Structural heart disease should be suspected in the presence of abnormal murmurs, a displaced or enlarged apical impulse, signs of heart failure, or a history of myocardial infarction or cardiomyopathy. In such cases, palpitations must be evaluated with heightened vigilance.
A 12-lead ECG is mandatory in every patient presenting with palpitations. Although it is often normal in intermittent symptoms, it provides a crucial baseline rhythm assessment. Even subtle abnormalities on a resting ECG can indicate underlying electrical or structural disease and help identify patients who require closer follow-up. Specific ECG findings can strongly suggest the underlying cause. An irregular rhythm points toward atrial fibrillation or flutter. A short PR interval with a delta wave is characteristic of Wolff-Parkinson-White syndrome. QT prolongation signals an increased risk of ventricular arrhythmias. Pathological Q waves suggest prior myocardial infarction, while AV block indicates conduction system disease. A baseline ECG plays a key role in risk stratification. It helps identify patients at higher risk of serious arrhythmias, guides the need for further monitoring or referral, and is essential before initiating antiarrhythmic drugs. In many cases, it shapes the entire diagnostic and management strategy. Most palpitations are paroxysmal and unpredictable, making them difficult to capture on a routine ECG. The primary goal of ambulatory monitoring is to achieve clear symptom-rhythm correlation. Selecting the appropriate monitoring method depends largely on the frequency and pattern of symptoms. Several ambulatory monitoring options are available. Holter monitors record continuously for 24 to 48 hours and are useful for frequent symptoms. Event monitors and patch monitors, such as the Zio patch, allow longer monitoring over 2 to 3 weeks. For very infrequent or unexplained episodes, mobile cardiac telemetry and implantable loop recorders provide extended and highly sensitive monitoring. Choosing the right monitor is critical for diagnostic success. Daily symptoms are best evaluated with a Holter monitor. Weekly symptoms are more effectively captured using event recorders or patch monitors. Rare or sporadic episodes require an implantable loop recorder. A patient-maintained symptom diary greatly enhances diagnostic accuracy. Despite its usefulness, Holter monitoring has limitations. Its diagnostic yield is low in patients with infrequent palpitations, and a normal Holter does not rule out arrhythmia. In such cases, longer duration monitoring is often more informative and clinically valuable. Exercise testing is particularly helpful when palpitations are exertion-related. It assists in evaluating suspected coronary artery disease and identifying rate-dependent or exercise-induced arrhythmias. In patients with chronic atrial fibrillation, it can also be used to assess adequacy of ventricular rate control during exertion. Echocardiography is a cornerstone investigation in palpitations. It detects structural heart disease, evaluates left and right ventricular function, and assesses valvular abnormalities. Echocardiographic findings are central to risk assessment, prognosis, and long-term management decisions. Laboratory tests help identify reversible and systemic causes of palpitations. Essential investigations include thyroid function tests, hemoglobin levels, serum electrolytes, and blood glucose. A toxicology screen should be considered in selected patients when substance use or drug toxicity is suspected. Management of palpitations begins with clinical prioritization. The foremost objective is to exclude life-threatening arrhythmias and structural heart disease. Once serious causes are ruled out, treatment should focus on addressing the underlying trigger, avoiding known precipitants, and providing clear, confident reassurance. Thoughtful reassurance backed by sound evaluation is often the most effective therapy. In patients with premature atrial or ventricular contractions and a structurally normal heart, management is largely conservative. Lifestyle modification forms the foundation of care. Limiting caffeine, tobacco, and alcohol frequently leads to substantial symptom reduction. When symptoms remain troublesome, low-dose beta blockers may be used judiciously to improve quality of life. When a clinically significant arrhythmia is identified, management becomes more targeted. Supraventricular tachycardias may be treated with vagal maneuvers, pharmacological agents, or catheter ablation, depending on frequency and severity. In atrial fibrillation, management includes rate or rhythm control strategies, along with appropriate anticoagulation to reduce stroke risk. Ventricular tachycardia represents a high-risk condition and requires immediate specialist intervention. Certain presentations warrant urgent referral or hospital admission. These include palpitations accompanied by syncope or presyncope, the presence of an abnormal ECG,
known structural heart disease, or suspicion of a ventricular arrhythmia. Recognizing these situations early can be critical and at times life-saving. The prognosis in palpitations is generally favorable. Most palpitations are benign, particularly in patients without structural heart disease. A carefully taken history remains the most powerful diagnostic tool. Investigations should be targeted and appropriate, and monitoring tailored to symptom frequency. Perhaps most importantly, clear explanation and reassurance significantly improve patient outcomes. Always remember, treat the patient, not merely the rhythm on the monitor. Thank you for spending your time on this comprehensive discussion of palpitations. I hope this session has helped you approach this common yet complex symptom with greater clarity, confidence, and clinical precision. If you found this lecture useful, please like, share, and subscribe to support the channel. More postgraduate-focused, clinically practical medicine lectures will follow. Until then, stay curious, stay compassionate, and keep practicing good medicine.